call you this unit central nervous system 2. So I want us to start on the general anesthetics, and if we are able to finish, we can continue on with the muscle relaxant, central reactive muscle relaxants. Fortunately, these two topics are simple topics. They are very, very simple topics compared to the other topics that we study. These ones are comparatively very, very simple, but of course, nevertheless, also important. So first of all, we just do an introduction. I don't know whether you've looked at like local anesthetics. They will have similarities, they will have differences, perhaps on the ideal characteristics. There could be similarities, but of course, general anesthetics, as we are aware, they are working on the brain, so they will have their own very, very unique characteristics. So start with the introduction. As I say, these are not difficult things. Definition: general anesthetics are a group of drugs that produce loss of consciousness and therefore loss of all sensations. We are aware that general anesthetics are used in the theater, of course, when a patient requires surgery and they require to be unconscious. So we are saying they will bring about loss of consciousness and therefore loss of all sensations. The absolute loss of sensation is termed as anesthesia. General anesthetics bring about descending depression the central nervous system, starting the cerebral cortex, the basal ganglia, the cerebellum, and finally the spinal cord. So they will depress the central nervous system, and therefore once they depress the central nervous system, of course, as we are going to see, you do have a mixture of drugs with different characteristics, so that you will have even those which will bring about analgesia, those ones which will bring about loss of consciousness. So we do have a mixture of drugs so that the anesthesia can be highly effective. These drugs are used in surgical operations to induce unconsciousness and therefore abolish the sensation of pain. Stages of general anesthesia. And of course, this you do in details in pharmacology, but it's just good to mention that when an inhalation, you're going to classify the general anesthetics. Well, of course, inhalation means you're inhaling it. So when an inhalation anesthetic is administered to a patient, some of the following very well-defined stages are produced by increasing the blood concentration of the agent. We have about 4 stages. The first stage is what we are calling the anesthesia, and this is from the beginning of anesthetic administration to the loss of consciousness. So up to the time now you lose your consciousness. From the beginning, the patient progressively also loses pain. This stage is also called the analgesia stage. Then you have the stage 2, delirium, and of course from the word delirium, you can definitely be able to understand that we do have some sort of excitement in that stage. This period extends from the loss of consciousness through a stage of irregular and specific breathing to again re-establishment of regular breathing. So it's like it's quite it is a kind of session. You start from normal breathing, you go to irregular breathing, and then you go back to regular breathing. So it's a period. You observe that period as you, of course, remember every time you are doing giving a general anesthetic, you do have an anesthetic around, somebody who has studied administration of a GA or administration of general anesthetics. That is their profession. That is what they studied at the university. They are medical doctors, but their major is in administration of anesthesia, because you do it wrong, the patient will die. Respiration is not, so the respiration goes back to normal and it is regular. The patient may laugh, vomit, or struggle. And of course, because of the vomit, remember this patient has lost consciousness, so you must be very careful, because if they vomit, they can't even the vomit can even get them. What use that word? They can't even. Can even choke them. The vomit can even choke them. So you must be very, very careful that you place them in a proper position so that they are not choked by their own vomit. And for this reason, it's called state of excitement. There is laughter, and therefore that's why we are calling it state of excitement. The other one is surgical anesthesia. And in this stage, excitement is lost. And of course, we have the skeletal muscle relaxation. And for sure, when you operate, you want to have skeletal muscle relaxation. Most types of surgeries are done in this stage 3. Then, of course, the fourth one is now when you give the overdosage, and therefore you will have medullary depression. Overdosage of the anesthetic may bring the patient to this stage, respiratory and circulatory failure occur, and that now is a very, very dangerous stage. That's a very dangerous stage. So of course, you'd want from stage 1 to stage 3 to run very smoothly. You'd want from stage 1 to stage 3 to run very smoothly, and you get to stage 3, and then you maintain the dosage of your general anesthetic at that particular concentration that gives you stage 3, so that you do not either go lower or higher. If you go lower, then of course you will the patient will not be very comfortable because they're unconscious. But remember, sometimes even when you are unconscious, sometimes you can feel the pain, and that's why even when we do this surgery, we do give a lot of very, very, very strong analgesics so that the patient is not having any discomfort. So you must make sure that there's proper control of the general anesthetic so that you maintain the stage 3, which, as we have said, is the stage for the operation. Then when we talk about general anesthesia, as I had said, it involves an addition of quite a number of drugs, so that now you need something for the pre-medication, you need something to induce the anesthesia, and you need to have, of course, a maintenance agent so that the patient, because you see, we have said the muscles need to relax, so you do need to give muscle relaxant. There should not be pain, because although you are unconscious, you can have pain even in unconsciousness. So you give painkillers so that this patient is not in any pain. So pre-medication, prevention of bradycardia, bronchial secretions, and muscle spasms. You can give these benzodiazepines, for example, diazepine. You can give narcotic analgesics, which you just studied. Like, of course, you have the drugs, like the fentanyl. I believe we mentioned it. Drugs are like fentanyl. That is the anhydropiperidines are very, very good at being used as narcotic analgesics for as general anesthetics. You can also give anticholinergic drugs. These are to minimize these secretions. And then, of course, we have said you can also give skeletal muscle relaxant. So you do give a mixture of several drugs, because no one drug can have sufficient activity, cannot have all the necessary properties that you require. So normally you do give a mixture of quite a number of drugs to get what you want. Then you have the inducing agent, normally an intravenous anesthetic. Again, we are going to classify the drugs. There are those which are intravenous, there are those which are inhalation, and so on. So normally an intravenous, and these again, we have looked at them. We have looked at the barbiturates, where you have the pentosan sodium or thiopental sodium, and methotrexate or methotrexatone. We have the non-barbiturates, we have ketamine, and we have propofol. So those ones, you give them as inducing, and they must have good characteristics. They must have a rapid onset of activity, very rapid, so that the minute the patient inhales, there's a knockout. So they're knocked out, and of course they go unconscious. You, of course, also within the concoction, you also have, as we have said, the other drugs, and therefore the patient within a very short time is ready for the operation. Remember, you want to maintain the patient in this position for a very short duration. Then you must, of course, maintain the anesthesia so that the patient does not wake up during the surgery, because there are surgeries that can take up to 7 hours or even more. So you do require to maintain the anesthesia. You can either do it normally with the inhalation and anesthetic, and you can also use halogenated hydrocarbons and ethers, or you can also use nitrous oxide. So these are some of the anesthetics that you now give continuously. You give continuously so that you maintain this patient under anesthesia. Then, as we had said, sometimes there can be vomiting. So antiemetic agents may be required post-anesthesia to prevent. Remember, even when the person wakes up, their muscles are still relaxed. So if they vomit, they can still choke. So you must be careful again to give them antiemetics to help them not to vomit. Classification. One of the classifications we can do is as per the nature of the anesthetic, and that is the general anesthetic may be classified according to their nature, whereby you can have volatile or non-volatile at room temperature, and they are volatile inhalation general anesthetics. So you can have, so we have the first one, the general, you can either classify them as volatile or non-volatile at room temperature. We start with the volatile inhalation general anesthetics, and they are administered for sure through inhalation, and we can further subdivide them into, you have those which are gases like nitrous oxide, cyclopropane, ethyl chloride. These are gases. And you have those ones which have the ethers, such as the diethyl ether, halothane, chloroform, and trichloroethylene. These are liquids. So we can, but they are volatile liquids, so the patient can still inhale. Of course, the gases are gases, and definitely they will be inhaled. Non-volatile, or which one, the ones we also call intravenous, and they are non-volatile at room temperature and administered by intravenous route. Of course, the intravenous route, as we have done in pharmacology, it is the fastest route, because you're putting the drug directly into the blood, and therefore if the drug has the proper characteristics of good lipid solubility, because remember these drugs must penetrate the BBB, it has good lipophilicity, it will get into the blood, penetrate the BBB, hit the mind, and almost immediately you will get activity. And therefore there we have the barbiturates. We have studied the barbiturates, and we have looked at the SAR of barbiturates. We have discussed in details. So you would still remember those basic characteristics of the barbiturates which we had discussed. But there are specific barbiturates which we had mentioned, or which have a very high lipid solubility. But do remember, when they have the very high lipid solubility, very rapid onset of activity, but unfortunately they will have a short duration. So that's why we say you use them for inducing, because they have got a rapid onset, but they cannot maintain, because they have a very short duration. Because you remember we did mention, with these drugs with very high lipid solubility, when they get into the brain, there will be depotization, they will be distributed within the tissue surrounding the site, and therefore there will be loss of activity. So we have thiopentasodium, we have methohexyl of course, given as their salt for improvement, of course, of their solubility, so that they can be given as IV drugs. Non-barbiturates, you have propanidine, and of course the one we will discuss is a propofol. So we will be able to look at them a little bit later. Classification per route of administration. So that was their nature, whether they are volatile or non-volatile. You can also class, of course, and depending on their nature also gives a route of action, a route of administration. So it's almost, when you look at their nature, indirectly you're also classifying them according to their route of administration. Inhalation, and we have all the pulmonary anesthetics. As we have said, these are gases or vapors of volatile liquids that are inhaled in a mixture with air or oxygen. Again, you don't give them without air, you give them as a mixture of air, or you can mix them with oxygen. Of course, remember, you do require, you're giving them through the passage where, of course, air passes or oxygen passes, so you need to mix them, so because the person still needs the oxygen to move into their body tissues. Then you do have the intravenous anesthetics, agents that are psychologically well tolerated, useful as induction agents for inhalation anesthetics. So you use them to induce as inducing agents, and then after some, once you do the induction, then you can give, as we said, for maintenance, you can give the inhalation anesthetics. Usually the intravenous, you do not give them for maintenance, you induce with them, and then you give the others for maintenance. Combination anesthetics, again, you can combine. Combination therapy is always good, because sometimes, of course, it can be advisable, it can have negative effects, but more often than not, when you combine drugs, you give the single drugs at much lower concentrations, and therefore you get lower toxicity. Of course, the exposure to very many drugs at the same time can result in increased toxicity, but more often than not, because the single drugs, the individual drugs are given in low concentrations, normally we have lower toxicity. Also, because some of these drugs, the drugs you give, they have different mechanisms of action. So you find you increase the efficacy of those drugs, you increase the efficacy of the drugs. Of course, these are not antibiotics, therefore, we are not talking about any resistance. But when you do combine drugs, there is better activity and there is lower toxicity. So we are saying a combination to broaden the therapeutic range, administration of minimal dose of individual drugs to achieve certain goals of anesthesia. So you are giving minimal drugs, minimal, so that you can attain the stage 3, as we have said, is what we want as a surgical stage. Now, these are some of the drugs that we are going to look at. There is halothane, which we all know. And you can see, like, this is a halogenated hydrocarbon. Halogenated hydrocarbon. You can see it has that carbon there, it has that carbon there. So it's an ethane. But with a lot of halogen, fluorine. In fact, halothane has all the 3. It has fluorine, it has chlorine, it has bromine. And then we have enfluorine. Enfluorine, if you look at it, it is an ether. You can see that oxygen there, and that, of course, it is a halogenated ether. Again, you can see the several. You can see the several. You can see the several halogens. Just 1 minute. So this is kind of horizontal orientation made it very different. And then this one you can see the fluorine. So if you look at all these structures, you will see there's a lot of structural difference. There's a lot of structural similarity, as well as structural difference that brings in the change over. The pentostatin, that's a 7-member tree rather than the kawaida 6-member tree, and that for sure brings about a difference in from kawaida 6-member tree, and that for sure brings about a difference in from inactivity. So that is the second one, where we have also the purine, and you can also have. Sorry for that interruption. So if you look at enfluorine, you can see, as I was saying, it's an ether, that is oxygen, and you can see we do have a lot of the halogens. We are going to discuss why do you require the halogens. Isofluorine, if you look at it again, it is an ether. And if you look at enfluorine, I hope you can see something, you can see the connection or the relationship between enfluorine and isofluorine. If you look at enfluorine, you can see these 2 fluorines there. These 2 fluorines, if you move them to this position, you will have them here. And then this chloro and hydrogen, you move it to this carbon. So this chloro and hydrogen, you move to this carbon. These 2 fluorines, you move to that. Which means enfluorine and isofluorine are what we call constitutional positional isomer. They're just isomers. They're constitutional positional isomer because they're different. They have the same condensed molecular formula. Their difference is the position of the substituents. The substituents, their position, whether they're in carbon 1 or carbon 2, that's the only difference. But they have the same condensed formula. Then you have desflurane. Again, it is also an ether, and you can see also it has quite a number of the halogens. Then you have methoxyfluorine, same. So most of the ones we have are halogenated ethers, and then you can see nitrous oxide. This is our gas or laughing gas, and then you can see cyclopropane. Those are simple structures that we have looked at before. So you can draw the structures of the various. Some of this. Of course, we will also draw the structures of the others like ketamine, propofol, as we move on. Characteristics of a general anesthetic. Of course, you must have an ideal. It's almost impossible to have an ideal drug. It will have some shortages here and there, but you try the best you can to pick one which has most of the positive characteristics. So an ideal general anesthetic should possess the following characteristic features. One, it should be inert, it should be potent and non-flammable, it should be non-irritating to mucous membranes because it will cause a person to really cough. They will be trying to cough, it to irritate the mucous membranes, and of course it will harm them also. It should produce rapid and smooth, very rapid and very smooth anesthesia. And that's why when you go to theater, if you have gone to theater, they try to ask you, what is your name? Or count 1, 2, 3. Even before you finish to count number 3, you are gone. Even before you finish saying your name, you are gone. So you're saying rapid and very smooth. You should produce analgesia. See, analgesia, that means there is no pain and muscle relaxation in addition to anesthesia. Of course, if it's not able to do so, as we have said, you can add other drugs. So, but if it could, the better, because it will lessen the number of drugs that you'll be giving this patient. Should not produce severe hypertension, should not produce nausea and vomiting, should be compatible with the adjuvant drugs used in anesthesia. We talked about you can use analgesics, you can use muscle relaxants. Should be economical, it should have a fair price. Of course, cost effectiveness. When you talk about economical, we are talking about cost effectiveness, that it has a fair price, but a good price for, and of course it is safe and it has good activity. So it has a good price, it is safe, and it is efficacious. That's what we talk about. When we talk about drugs, we talk about cost effectiveness. Should be stable to heat, light, and alkali, so that when you give it, it will be stable, it will not break down. Because if it does break down, if it's not stable, it means that we will give it as this to be metabolized, and of course, we will not know the activity of the metabolite and so on. The mode of action, we are of course talking about these drugs being depressants. So they will make sure that they will depress the excitatory pathways. They are depressants, and more often than not, they depress the excitatory pathways. They decrease also the release of calcium ions, and therefore bring about the inhibitory activity. So they can block the N-methyl D-aspartate, that's the NMDA, N-methyl D-aspartate, and glutamate control channels. The above receptors in the CNS are activated by the excitatory amino acids, neurotransmitter glutamic acid, and even glycine. Then what do the agonists do? The agonists, the activation opens channels, allowing potassium ions to flow to the extracellular fluid and sodium and calcium ions to flow into the nerve cells. So they will release, when you have an agonist, you bind on these NMDA receptors and release calcium. Calcium is used for nervous conduction. So they will release calcium and bring about nervous conduction. The increased intracellular calcium ion activates the liberation also of nitrous oxide, which causes alertness or also consciousness. Antagonists like ketamine, they will block this NMDA, causing CNS depression or anesthesia. So remember, these are excitatory pathways excited by glutamate and even glycine. So once you block those pathways, then definitely you will bring about CNS depression. The mode of action, general anesthetics target the ligand-gated ion channels and produce the anesthetic action. In other words, they can also have an influence on the opening and closing of the channels, like the chloride channels. The chloride channels, the chloride channel is also inhibitory. So it is inhibitory. So if you bind as an agonist on the chloride channels, because they are inhibitory, then you will bring about depression of the nervous system. The GABA receptor-gated chloride channels are the most important sites and opens to perform the inhibitory action. So the GABA, as we are saying, the chloride channels, of course, they are within the GABA receptor. They are inhibitory in nature. So if they are excited, they will bring about the inhibitory action and, of course, the CNS depression. And nitrous oxide and ketamine do not affect the GABA or glycine-gated chloride channels, but they selectively inhibit, as we have said, the excitatory NMDA type of glutamate receptor, which belongs to calcium-gated channels in the neurons and leads to neuronal hyperpolarization. So they will bind these channels, they will bring about they will inhibit the release of calcium, and they will also bring about hyperpolarization. Once that happens, then for sure you will have the CNS depression. Once you have, of course, the CNS depression, you have your anesthetic activity. Sometimes they do say that it is a bit hard to understand some of these modes of actions, but basically those are the mode of action of the general anesthetics. So we look at the first class of the inhaled anesthetics, and we are starting the nitrous oxide, which is also known as the laughing gas. It is a colorless gas, exerts low anesthetic effect. So you do not really want such a drug. You'd have to use it mixed with others, because we said you want a drug which has good effect, which has rapid onset of activity, but the nitrous oxide is not highly effective. It's not very highly active. Therefore, you need to mix it. So it's mixed with oxygen and ether or halothane, as deep anesthesia cannot be achieved with it alone. We have said it has low anesthetic activity. You can mix it. As we had said earlier, combination. Combine several drugs to get the extent of anesthesia that you want. Good analgesia and minimum toxicity. So it has good analgesic, it has analgesic activity and has minimal toxicity, but poor muscle relaxant effect. That means if you're giving it, you must also combine it with a muscle relaxant. But it has good analgesic activity. Then we have the non-halogenated hydrocarbons, and as you remember, the main one we saw as a non-halogenated hydrocarbon was the cyclopropane. Cyclopropane, of course, is a cyclic hydrocarbon. It's a cyclic hydrocarbon. It produces cardiovascular toxicity. So, of course, that is a negative cardiotoxicity. The longer chain of the hydrocarbon, the longer the chain of the hydrocarbon, the higher the potency. Why would we say the longer the chain of the hydrocarbon, the higher the activity? And of course, why would that be? Plus, why would that be? Why would that be? That the longer the chain, the higher the potency? Can I get an answer, please? We are only 23. So why the longer the chain, the higher the potency? And would the length of the chain be indefinite? Why are we saying the longer the chain, the higher the potency? You have so many who are not there, only 23. Where are all the others? Students have one. And then your students is difficult. Not moving. Quickly, can I get some answers, please? This one. Move this thing. Quickly, please, students, give me an answer. Or have you given any answer? Move, but it's not moving. That one is moving. refused to move, to scroll. It's not scrolling. Have I gotten any answer? Because this thing has refused to scroll kabisa. Oh, yeah. And it's scrolling well. Sorry, I lost my connection a bit, but it's back. Sorry about that. So I was asking a question. Remembered? The question was, I hope you have an answer. I think we go back, we continue because of time. So I was asking, how come the longer the chain, the longer the hydrocarbon chain, the higher the potency? And I hope the answer you've given is that you see these are hydrocarbons. Hydrocarbons are known for their lipid solubility. Of course, the longer the chain, the longer the hydrocarbon chain, the higher the lipid solubility. These drugs must penetrate the BBB. So, of course, also the lipid membrane. So, the higher the lipid solubility, the better the penetration of the BBB, the better the distribution into the brain, and therefore the higher the potency. Of course, it has to go to a maximum. You cannot have, again, N. Of course, we're saying CH2 to the power N. It cannot be infinite because you cannot also compromise on water solubility. Of course, if also the N is very large, then of course that compound will have very extremely high lipid solubility. There will be a lot of deputization. It will not even get into the brain because it will be deputized, or it will be it will be sequestered into the lipid membranes, and therefore it will never get into the brain. So that's why we are saying I hope that's the answer you had. So we are saying the longer the chain of the hydrocarbon, the higher the potency. This drug, of course, for cyclopropane, of course, is an example. But now we are talking about the halogenated hydrocarbons, that the higher the hydrocarbon chain, the higher the potency, of course, to a maximum, because as I have said, because of depotization. It's colorless, it's explosive, it is flammable. You can see explosive, flammable. It can also cause a radical spasm. So therefore, you can see it is not really ideal. It's not an ideal. It doesn't have the ideal characteristics as we have already discussed, and therefore we don't use it much. It can be mixed with 15 to 30%. You have 15 to 30% of the cyclopropane mixed with oxygen for medical use. But as we have said, there is, of course, initially when we didn't have many of them, of course, it could be used, but now we have quite enough, and therefore it is not in much use, especially when it's flammable, very dangerous, because you can set the whole theater in. You can set the whole theater on fire. In contrast to nitrous oxide, its concentration of 20% can produce anesthesia. So it's a little bit more potent than nitrous oxide, but it has more disadvantages in terms of being an ideal general anesthetic. The SAR, or volatile structure activity relationship, or volatile general anesthetics, the potency of alkanes, cycloalkanes, and aromatic hydrocarbons increases in direct proportion to the number of carbon atoms in the structure up to a cutoff point. We've already discussed that. So you will increase up to a maximum, and when again the activity starts going to go down. In the N-alkanes, the cutoff, that is the straight chain. N-alkanes are the straight chain. The cutoff number is 10, while in the cycloalkanes it is 8. So the cycloalkanes have been found to be more active. There is a positive correlation between anesthetic property and solubility in oil, or what we are calling the lipid water partition coefficient. The lipid water partition coefficient is also a measure. It's a measure of their lipophilicity. So the lipid water partition coefficient, which is also a measure of the lipid solubility. So we are saying, of course, the higher the lipid water partition coefficient or lipophilicity, of course, the higher the penetration of the membranes to a maximum when you will have depotization. The cycloalkanes are more potent anesthetics and straight chain analogs with the same number of carbon atoms. Then from there we go to the halogenated hydrocarbons. We have seen in the non-halogenated or in the hydrocarbons only cyclopropane, which was found worthwhile. Then halogenated hydrocarbons, effect of halogenation, ether, and of course halogenation of the hydrocarbon or ether halogenation. And as we have seen, these compounds will have fluorine, they will have chlorine, and they will even have bromine. Some of them, like even halothane, has bromine, and therefore there must be a reason. And we will see that, of course, the addition of halogens to eliminate reduces flammability and also increases potency, and that is why you find that the halogenation, it also reduces their volatility. So we are saying addition of a halogen reduces or eliminates flammability and increases potency. The higher the atomic mass, the higher atomic mass halogens increase potency compared to the lower atomic mass. So in other words, when you start with, I believe you start with fluorine, you go to bromine, you go to chlorine, and then you go to iodine. So we are saying the higher the atomic number, the higher the increase in potency. That's why you are putting almost all of them, because they have some use. Higher atomic mass halogen increase potency compared to low atomic mass halogens. For N-alkane series, fully saturating the alkane with fluorine abolishes activity. So you cannot again, for the N-alkane, that's again straight chain, you can't again saturate, you cannot remove all the hydrogens and replace them with halogens or fluorine, not unless if you are talking about methane. Methane is the only one where you can replace all the hydrogens with fluorine and still replace and still retain activity. And we are there. That's why even when you look at the structures, we are seeing there are some hydrogens which are still within the structure. That is because those hydrogens are needed for activity. When N is 2 carbons, that is this N here, when it is 2 carbons, the highest potency was seen when the terminal carbon contained one hydrogen. In other words, when that was a 2, it was found that if this carbon also retains a hydrogen and that carbon also retains a hydrogen, then there was maximum activity. Sometimes that is not followed to the letter. You might find that this is a trifluoromethane group, but this is a difluoro. If you look at most of the compounds, at least you will find, even if not both carbons, all have hydrogen substitution. At least one of them will have a hydrogen substitution. And we are realizing that that was because when the trials were being done or when the tests were being done, it was found that the hydrogen increased activity. All when you have at least one hydrogen at the first and terminal carbons or the terminal carbons, then there was much higher activity. When N is greater than 5 carbons, the potency decreases in these cells. Again, remember we did mention when you have too many carbon atoms, that would be 7, because if this is 5, then 6, 7. Then, as we have said, the compound we have to have very high lipid solubility, very high lipid water partition coefficient, depolarization, no activity. So that's what we're talking about. The rate of metabolic defluorination that we look at it when you look at methylation, when you're looking at metabolism. Let us say something about halothane, and I believe this is the structure of halothane. You can see, as we have said, this first carbon, all the hydrogens are replaced. But you can see for the second carbon, at least we have a hydrogen there. And that is because we are saying that is important in increasing activity. The chemical name is 2-bromo, 2-chloro, 1,1,1 trifluoroethane. And I think that one we can see from the structure. 2-bromo, we're starting from here, number 1, number 2. 2-bromo, 2-chloro, 1,1,1 trifluoroethane, 1, 2 carbon atoms. So that is where they're getting the name from. We don't have to remember those ones. It is non-inflammable, and we have said, of course, high level of the halogens helps in that. It's a non-inflammable liquid with a characteristic sweet odor. Presence of free fluorine atoms increases potency, volatility, and also chemical stability. It increases the potency, it also increases the volatility, and also increases the stability. And of course, when it increases its volatility, it means it's much easier to be inhaled. It increases potency and also the chemical stability. So those 3 things are very important: potency, volatility, and chemical stability. Gives rapid induction and recovery from anesthesia. This again is very important. We said we want a drug which has a rapid and smooth induction. And not only do you want to have a rapid and smooth induction, you want to also to have a fast recovery. That once you are done with the patient and the patient is in recovery ward or they are waiting to recover, they don't stay there forever. That means that any drug which is in the body is either being metabolized or it's flowing back and it's being exhaled. So therefore, we also do require the drugs to have very rapid, good recovery as well as rapid induction. It reduces peripheral vascular resistance. Of course, we did say there will be hypotension, but we require a drug that does not reduce. Once you reduce peripheral vascular resistance, you will, of course, reduce the pressure, and of course, the drug can cause hypotension. And we did mention about that. But as long as it's safe, therefore, you must control again the drug very well. It's a poor muscle relaxant. We had said the drug should be a good muscle relaxant, but there, that means you must combine it with muscle relaxants. Mostly eliminated intact, about 20% is metabolized to trifluoroacetic acid. You will see the danger of that metabolite. So we are saying once you stop administration, then the drug can now come from the brain, go back into the blood, and come back. See, once you stop administration, it means in the lungs, the concentration of the halothane or the partial pressure of halothane in the lungs will be very low, once you stop administration. When you are administering, the partial pressure of the halogen within the lungs will be very high, so it will push the drug into the blood and of course into the brain and so on. But now once you stop administration, the concentration of the drug within the lungs will go down, and the partial pressure of the drug within the lungs will go down, and therefore the concentration of the drug in the blood is too high, then it will diffuse out. So it will just diffuse out, go into the lungs, and now you exhale it. And that is one way, of course, you will be able to recover. Of course, some of it will be metabolized, and as you see, metabolites do cause toxicity. The trifluoroacetylchloride metabolite is electrophilic and can form a covalent bond with proteins, leading to immune response and halogen hepatitis upon repeated use. So we are talking about this immune response and halogen hepatitis upon repeated use, or it can cause hyperthermia. So again, therefore, this is one condition that one has to be very careful about when they give halogen, and you can see it has been caused not by halogen itself, but by its metabolite. So metabolism of halogen. So there is a halogen. The first thing that happens is, of course, you have that hydrogen, so there will be oxidative hydroxylation. So that is, or another oxidation. There will be oxidation, because so there will be oxidation there. And once you have that oxidation, you can see these square brackets. This is a very, very unstable compound, and because this is a very unstable compound, it loses hydrogen bromide. So it will lose hydrogen bromide, this hydrogen here and this bromine, and that will result in this double bond there. And then this compound, then again you lose a chloro group here. So it's losing a chloro group, and once it loses a chloro group, then of course this is of course, remember in the body, of course, you have, it is an aqueous, it's an aqueous environment. So of course there is water, and therefore that will form a trifluoroacetic acid. And once it gives us trifluoroacetic acid, this is what we are saying is dangerous. And it is dangerous because, do remember, this oxygen there is pulling away electrons. This oxygen there also is pulling away electrons. This carbon here, this carbon there, that one, I lost the marker. So this carbon here, that one there, is definitely having a delta positive. As I have said, the high electronegativity of oxygen, the high electronegativity of this oxygen, this one pulling electrons that way, and this one pulling the electrons this way, and therefore this carbon here being deficient of electrons. And once you have an electrophile in the body, it can be very dangerous, because within the proteins you have amino acids like cysteine, which have sulfhydro groups, and sulfhydro groups are rich in electrons. They will donate the electron, and all this compound will bind sulfhydro all nucleophilic centers, and therefore can cause a lot of toxicity. So therefore, especially on repeated use. So that is the major disadvantage of halogen. Then we look at the halogenated ether. So the only halogenated hydrocarbon that is used as a general anesthetic is halogen. So now we look at halogenated ethers. These are polyfluorinated ethers. Polyfluorinated ethers have analgesic and muscle relaxing properties, but are more difficult to control. So they're more difficult to control in terms of their concentration and their dose, and that can be a disadvantage. Some are also inflammable. Remember, of course, we did mention that they should be non-flammable, and of course, they should be controllable. You should be able to control the dose, because as we said, if you miss and you give too much, you will get to stage 4. If again you do not control the dose well and it wears off, you go to stage 2. And remember, we said you must maintain the patient in stage 3 because that is the best stage for surgical operation. Then we look at the first one, which is enflurane, 2-chloro-1,1,2-trifluoroethyl difluoromethyl ether. It is non-inflammable liquid mixed with various amounts of oxygen and nitrous oxide. Of course, you remember, so this is a combination therapy. Mix it with nitrous oxide. Remember, we said nitrous oxide has good analgesic activity, but we did mention you cannot get a good analgesia or good anesthesia with nitrous oxide alone. So you mix it with that. It has a more rapid induction and recovery than halodine, which is an advantage. Remember, we said the more rapid the induction, the better. Less frequent arrhythmias, has a low frequency of nephrotoxicity due to low fluoride downs released from metabolism, very low amounts metabolized to fluoride downs and difluoromethoxy, difluoroacetic acid. So if you look at, we are saying this, and also the ones which are also, these fluoride downs have been found to cause nephrotoxicity. Of course, also the acid, this acid, because of the fluorines, this carbon here, because of the fluorine and this carboxylic group, this carbon here could also be a positive carbon and can cause toxicity. But we are saying a very little of it. Remember, for the metabolism of halotene, I think we say 20%, if I'm not wrong. Yeah, we say 20%. So you can see this one, we are saying the metabolism is only 2%. So very little of it is metabolized, the toxic metabolite, and even to the fluoride downs, and those are the ones that are responsible, the difluoromethoxy, difluoroacetic metabolite, and the fluoride downs are the ones responsible for toxicity, but they are in very low concentrations and therefore making enflurane a safe drug. Drug interaction, it can interact with isoniazid, which facilitates its defluorination, renal damage occurs. So in other words, you cannot give it together or with isoniazid, or perhaps in a patient who is on isoniazid, because the isoniazid, we are saying it will facilitate or it will enhance defluorination. Fluoride downs will bring about more nephrotoxicity. Drug toxicity at high doses, it produces conversion, should not be used in patients with epilepsy. Relaxes the uterus, should not be used as an anesthetic during labor. So these are some of the very important things to note, because of the fact that they, of course, as we said, the drug the combination, whether it's a combination or it's a single drug, for sure it must be very safe, and therefore any toxicity or drug interactions must be highly noted and avoided. That's enflurane. And then from enflurane, so that's enflurane, we had its structure. I've carried the structures all along. That is the enflurane, and remember we did say enflurane and isoflurane will be the next one. We did mention, sorry. So if you look at enflurane again, you can see very high level of fluorine, 1, 2, 3, 4, 1, 2, 3, 4, 5. It has 5 fluorine atoms and 1 chloro group, and therefore highly fluorinated. And we did say when you fluorinate, you increase volatility, you also increase potency and all those other things that we said. This is also in the tendency to be inflammable. So we are now on isoflurane, and we are saying isoflurane is an isomer. It is an isomer, constitutional isomer of enflurane. Non-inflammable liquid with faint odor, has a low blood gas distribution coefficient, which leads to rapid recovery from the anesthesia. If it has a low blood gas distribution, that means the concentration in the blood will remain low, and therefore it will give out, when you are starting to recover, it will be able, the drug will be able to leave the blood and go to the lungs. That's what we're calling a low blood gas distribution coefficient, which is rapid recovery. So there will be rapid recovery, because that means the concentration in the blood will be low, and the concentration in the lungs will be high, and that is what we're calling the low blood. And therefore, again, very rapid recovery as we want. That's what we want. Minimal amounts of the drug again is metabolized to fluoride and trifluoroacetic acid. Remember, these are the compounds that we don't want. Therefore, kidney, liver, and myocardium functions remain intact. So isoflurane and the very again a stable drug. Dextro isomer slightly more potent than levo isomer, just a bit. About, I think one is 53, the other one is 47. So it's not really notable, but nevertheless, the dextro isomer is slightly more potent than the levo isomer. It's a good general anesthetic and is a structural isomer of enflurane. As we have said, it's a structural or constitutional positional isomer. It's a constitutional positional isomer. It's a structural isomer because the condensed formula is the same. It is the structure of the compound is different, and in saying the structure, it is that atoms, the way the atoms are joined to the carbons, you get that you have different atoms being joined to the carbon, and therefore the structure is different. Condensed formula is also, the condensed formula is the same. So they are constitutional positional isomer because the difference is not in the type, it's not in the type of the function, it's not in the type of the functional group, like one is an ether and another one is an alcohol. They are the same, they are both ethers, but the position of chlorine and the position of the fluorine atoms is what is different. Then the synthesis, you can look up the synthesis. It's a simple synthesis. You're starting with 2,2,2-trifluoroethanol, and you add the methyl sulfate. So this is a methyl group. Remember, when this is line notation, this line means a methyl group at this corner. That line there also means a methyl group. That's why we are calling it dimethyl sulfate. And you use potassium hydroxide, and then you get that product, and then you add chlorine. That you can get the names of these different products. You can look for their names. So you add you start that, and you add potassium hydroxide, you get that product. You add chlorine. This should not be a capital L, a simple L. Add chlorine, you get the dichloro product, and then now you use hydrogen fluoride. At least one can call it dihydrogen difluoride, difluoro, something like this, because it's 2 hydrogens, 2 fluorines. 2 hydrogens, 2 fluorines. I think I can call it dihydrogen fluoride or something. Dihydrogen difluoride, something like that. And then, of course, there is tin there, chloride, and you get now substitution of the chloro groups with the fluorine groups. Again, you add chlorine, and you get your final product. Kindly look up that. I didn't look it up. Look at it, look it up, and let's have the names of all these compounds. You can be able to get their names. You can also derive them. You have done a lot of chemistry. You can be able to derive those names by looking. Remember, when we name these compounds, these are ether. We decide which side we are going to consider as the ether, and which side we are going to consider as the substituent. So you must decide which side will you decide to be the ether, and which side will be the substituent, because one side is the substituent and the other side will be the ether, and that is why the way you name. So name them very well, get their names, and understand that synthesis. So that is for the halogenated ethers and the halogenated hydrocarbons. We have even looked at the SAR, and we have said the importance of the halogenation. So we move to the last class. As I say, these are simple drugs compared to the tough things we do. These are very simple. Then we move to the last class, which is the intravenous anesthetics. And again, there's some of this we have looked at. Perhaps, of course, ketamine is new, propofol is new, but the barbiturates are actually something we have looked at. So, and intravenous, of course, they are the IV anesthetics and are non-explosive solids, of course. They are non-explosive solids. They produce loss of consciousness, but insufficient anesthesia, and therefore normally we just use them for induction. As we have said, they produce very rapid loss of consciousness, but it is not sufficient. So normally we use them as induction and we do maintenance, as we have already discussed. Rarely used alone. Administration of oxygen is recommended, particularly with barbiturates and thiobarbiturates. One of them is propofol, because that's the structure of propofol. You can see it has an 1, 2, 3 isopropyl group there, another isopropyl group there, of course, and that hydroxyl group. This hydroxyl group being there is a center of metabolism, because when you see that center, the group there, that's a center of metabolism. It has a very simple structure indeed. I believe now you're used to doing very complex structures. It enhances the GABAergic neurotransmission in the CNS. Of course, we did say GABA is GABA triggers chloride ion opening, and that is an inhibitory neurotransmission. So if it enhances that, it means it will enhance chloride channel opening, and once that happens, then you will have inhibitory or depression of the CNS. It binds allosterically. Allosterically means it does not bind on the same receptor as GABA, and that we have done again when we were looking at benzodiazepines and barbiturates, and we did mention they bind an allosteric, not the same site as GABA, but an allosteric site, and bring about the same effect. Binds allosterically to GABA receptor at a site different from the benzodiazepines, and of course also different from the barbiturates. It achieves hypnosis in 1 minute and lasts for only 5 minutes. As we said, they do not have maintenance. Maintenance of anesthesia is achieved with volatile anesthetics or additional doses of it. So you have to give it as an infusion, or you give the other volatile anesthetics, because you can see it has a very short duration of activity. It is more effective than thiopentol, rarely associated with vomiting. Metabolism proceeds rapidly via glucuronidation and sulfur conjugation in the liver. So again, propofol is indeed a good general anesthetic. Of course, with the shortcoming, as we had already said, and we have said, the intravenous general anesthetics usually have a very short duration of activity, and they will not allow for maintenance. Again, so this is its metabolism. The metabolism, as we have already said, is simple. We are starting here. There is our propofol. You start here, but please note this would be an OH. That's an omission, because when you put it like this, it means it's a methyl group. So do correct here. This should be an OH, yeah? An OH there. So that's a propofol. So it can undergo oxidative. So that hydroxyl group there, it cannot go. Remember, this is a ring, so it cannot go oxidative hydroxylation. Of course, oxidative hydroxylation is usually catalyzed by the mixed function oxidases or the cytochrome P450 enzymes, and you can see hydroxylation of that position there. 1, 2, 3, 4. Of position number 4, there is hydroxylation to give us 4-hydroxy propofol. So that's one route of metabolism. And once you get the 4-hydroxy propofol, then it can readily undergo glucuronic conjugation, either at that hydroxyl group or at that hydroxyl group. So it can give us at that hydroxyl group, which will be 1-hydroxy propofol glucuronide, or it can undergo glucuronic conjugation at position number 4 to give us 4-hydroxy propofol glucuronide. So that can happen, or there can be sulfate conjugation to give us the 4-hydroxy propofol sulfate. So you can see this is the sulfate conjugation there. That is a glucuronic conjugation there. And also that's glucuronic conjugation there. Remember, more often than not, you cannot have two positions, either undergoing sulfate conjugation or undergoing glucuronic conjugation at the same time. Because the minute you add one glucuronide moiety, glucuronic moiety, or one sulfate moiety, the molecule has so much water solubility. Remember, sulfate has 4 oxygens. Glucuronic acid is where is glucose with the hydroxyl group, the carbon at position number 6, undergoing oxidation to the carboxylic acid. So again, glucuronic acid has a lot of hydroxyl group, a very high water solubility. So the minute you get just one molecule one molecule of glucuronic acid added, then the compound becomes very very highly water soluble, and therefore is excreted. Of course, the propofol also can directly undergo. So this one, remember, it's after undergoing hydroxylation on its own. Because of the presence of the primary hydroxyl group, it can undergo it can undergo glucuronic conjugation to give us propofol glucuronide. It can also be eliminated and changed, as we said. I think about 1% can be excreted and changed. And then this one, remember, when we were looking, I think, at the anti-cancers, we mentioned about NADP, quinone oxidase 1, remember, oxidoreductase 1, remember we mentioned NADP, quinone oxidoreductase 1, and again, that can happen, but this time it is oxidizing. So remember, those enzymes can either reduce or oxidize. So it was oxidoreductase 1. Can remember we were looking at the even anthracycline derivatives, which had a quinone, and we say they can undergo reduction. And once they undergo even mitomycin, they undergo reduction, and then we were starting, of course, with the quinone, and we were going to the hydroquinone. So this, we are starting with the hydroquinone and we are going to the quinone. So that enzyme, we had mentioned it sometime, and it is oxidizing that, this and this, to the carbonyl groups, of course, with loss of aromaticity. So that will be double bond, that will be double bond, definitely. That has a double bond, that has a carbonyl group, so they are satisfied. So that is a 2,6-diisopropyl azoquinone. So that is the compound that we get. And of course, that compound, as we see it, also can be toxic because of this carbon here, these carbons here. The quinones can sometimes be toxic because they are also very strong electrophiles. So that again, so I think those are the main enzyme, main pathways of metabolism of propofol. Again, because of the structure, the metabolic routes are not very difficult, and I believe we can understand all of them. That is propofol, and there is ketamine. That's quite a complex name there, methyl aminocyclohexanone, not very complex. That's a chlorophenol substituent, methyl aminocyclohexanone. It is a very potent and rapidly acting anesthetic agent. Give me a minute, I find out why there's so much noise. Sorry about that. So we are saying it's a potent, rapidly acting anesthetic agent, which definitely is very good. It, of course, when you look at its structure, you see it has It has a chiral center, so you can have the S dextro and the R levoisomer. We are saying it's the S dextroketamine is more potent than the R levoketamine as an analgesic. Of course, remember, as we said, for a good anesthetic agent, it should also have good analgesic activity. So for sure, we'd want to go for the one which has the higher analgesic activity. But unfortunately, sometimes, I'm not saying for this one, but for some of the drugs, you might find the one which has better activity also has more toxicity. So you must balance. Sometimes in some of the drugs, you find that even the one which has more better, let's say, which has better activity, might also have more toxicity. It also has short duration of action. It blocks the NMDA. We had said that. We had discussed that. It's suitable for diagnostic purposes and for surgical procedures that do not require muscle relaxation. That means it has poor muscle relaxant activity. It's indicated for children under 16 years because it causes wild dreams and hallucination in older ones. It is also hallucinogens. It's also a hallucinogen. When we are mentioning hallucinogens, we mention it. So again, you have to give it to a specific age. For children under 16, because it is not indicated for older ones. So again, it has its own limitations, but it is, even when you go to the hospitals, I believe you've already have done your ward rounds. I believe you have had the opportunity of going to the theaters. Definitely you have seen these drugs. Termination of action is due to its redistribution from the brain into other tissues, just as we have said of others. It's metabolized into norketamine, active metabolite in the liver, which accounts for its long duration of action. So you can see, so indeed, we normally give it as a racemic mixture, the RS, although we have said it is the dextroisomer, which is better, which has more analgesic activity. And if you look at it, of course, this is the chiral carbon here. This is the chiral carbon here. That's the chiral carbon. It is the one, it's the only carbon which has 4 different substituents, and therefore it's stereochemistry. So when we look at it again, if you look at it, you can see it has a chlorophenyl group. That, of course, this is cyclohexane, and then of course it has that secondary amine, and of course it's a hexanone. That's why we called it hexanone, from hexane. This is hexane. Therefore, it's, of course, it's cyclohexane. Therefore, that's why we got the word hexanone. And of course, it's a chlorophenyl group, and of course, it is also has that amine substituent. And if you look at this, because of this amine substituent here, it's an NHCH3. Because of that substituent, it has a methyl group, and therefore that methyl group can undergo oxidative end dealkylation. And if that does happen, this group here will be an NH2. And we are saying metabolite into norketamine, which is also active. So it's also an active. So it doesn't mean ketamine itself is not active, but ketamine is active, and the metabolite is also active, and that accounts for its longer duration of activity, because not only is it active, but its metabolite is also active. That gives us a long duration of activity. So you can see this, what we are saying again, oxidative end dealkylation is catalyzed by mixed function oxidases or cytochrome P450 enzyme, and you can see this one has 1/3 of the activity, so that prolongs the activity of this drug. It can also undergo oxidation on the hexanone ring, can undergo oxidation on the hexanone ring, and if it undergoes oxidation, it can either be oxidized at that point, or that point, or that point. So it can undergo oxidation either, and we can consider this to be number 1, number 2, number 3, number 4, number 5. So it can undergo oxidation of position 3, 4, 5. Remember, oxidation of the aromatic ring might not be very possible, because we have the chloro group, and we have said severally that chloro groups more or less than not. Of course, chloro groups bring about deactivation of the ring, and therefore the halogen, the aromatic ring is not readily oxidized. So those are the main routes of metabolism to give us norketamine, and also the hydroxyl derivative, and of course the dihydroxyl derivative can also undergo glucuronic conjugation and move off from the body. That summarizes propofol and both ketamine. You can even see even the structures, really very simple structures. You cannot compare them with some of the other more complicated structures, like some of the structures of the anti-cancers, especially the alkylating agents. They have very complex structures. So these are structures that we can easily remember. Ultra short acting barbiturates, again, of advantage is that these are drugs that we have looked at, and as I had said, we must remember the basic SAR, which we did when we were looking at the sedative hypnotics. Remember when we were looking at sedative hypnotics and anticonvulsants, and we are appreciating that you can have one class of drugs, but depending on the structure, you can have one class of drugs, but different members of that class can have different activities. When we look at the barbiturates, we did mention those we use as sedative hypnotics, diazepam being very good. And then we have those we use as anticonvulsants. So there are those we clonazepam. There are those ones we use as mainly, of course, all of them can be used as sedative hypnotics, but there are those specific ones or those particular ones that have specific activity, and you can pick some of them as anticonvulsant. And then even phenobarbital, use it as it's a barbiturate, use it as an anticonvulsant. And now we are saying we can also pick some of them and use them as general anesthetics. This is because, as we have discussed about the structure of the barbiturates, that the structure will determine the lipid water partition coefficient of that drug, or the lipid solubility of that drug. At position 1, we said, of course, barbituric acid will not have activity. Position number 5 must be completely substituted. We must replace the hydrogen of barbituric acid in position number 5. We said also the 2 nitrogens cannot be substituted. You must have a free nitrogen. And of course, we did mention about the total number of carbon atoms, between 4 and 10 carbon atoms for good activity. All this we have discussed when we were looking at the barbiturates. So we are saying now, for those barbiturates that have very large groups, large hydrocarbon groups or large groups at position number 5, where the total number of carbons is from 7 and onwards, those drugs now can be used as general anesthetics. They have very rapid onset of activity, and they will hit the brain, and of course they will not cause hypnosis. They will cause anesthesia. You will lose consciousness. Very, very powerful drugs. But of course, as we have said also, because of their very high lipid solubility, when they get into the brain, they will also start moving. They will also move to the surrounding tissues and move from the site, and therefore, or the receptor, and therefore they have also a short duration of activity. When we look at their structure also, sometimes you will also see they have centers of metabolism or areas where they can be very gently metabolized. So it's important for you to go back and remember the characteristics or the general structural requirements for barbiturates to have activity, because even these ones must meet those characteristics. It is only that their substituents at position number 5 must have a large number of carbon atoms to allow them to get into the brain, to allow them to bind the receptor very quickly and very powerful binding, and therefore not even bring hypnosis, but bring anesthesia. So they are used to produce rapid unconsciousness for surgical and basal anesthesia, and they are used as induction anesthetics, or they will induce the anesthesia rapid but short duration. So you must give them in combination. Induction is very rapid. Long side chain substitution at position 5 is an essential feature for increasing lipid solubility, and hence the rate of passing through the BBB. There is inverse correlation between the total number of carbon atoms substituted at position 5 and the duration of action. There is nothing new there. This is just, we are just reminding ourselves. Thiopentosodium, widely used ultra short acting barbiturates, The sulfur atom increases lipid solubility and facilitates its entry into the brain. It has a short duration of action, is due to the partitioning from the brain into the surrounding fats, or what you're calling depolarization or redistribution of the drug. It is metabolized by oxidative desulfuration. So you can remove this sulfur and you bring about back the oxygen, and that is one route of metabolism. And once you do that, of course, we had also discussed the other routes of metabolism, which you can go back to. Of course, if you look at this drug, it has also at this position 5, it has an ethyl group, and it has this 1, 2, 3, 4. It has 1, 2, 3, 4. That's a butane. In fact, you can say 1, 2, 3, 4. We can even go this way, 5. 5 is which one? 5 is which one? Tano ni ngapi? Tano tunaita nini? What we call the 5 one? Class. So definitely because of this, and this is of course, this is a hydrocarbon. That is a hydrocarbon. Hydrocarbons very readily, they will readily go penultimate metabolism. This is also an ethyl group again, undergo omega and omega -1 metabolism, and therefore their rate of metabolism is also high, and at the same time their redistribution is also high. It's metabolized by, of course, once you remove the sulfur and you put the oxygen, of course, you will change it to a different barbiturate, and that barbiturate might not really have anesthetic activity because you will reduce its lipid solubility. Methotrexate, again, I didn't say much, but I have requested you to refer. Don't say you are not told, because I can't again that, but I've also reminded you, but you need to refer to your notes on the barbiturates and look at the SAR of the barbiturates, look at the metabolism of the barbiturates in terms of the side chains, and of course this one of them is of course the desulfuration, but look at the other ways it can be metabolized. We had said they can also be hydrolyzed and so on, and also look at the SAR, the fact that of course, as I have said, this group should be, they should be between 4 and 10. We do require that dye substitution at position number 5. These 2 nitrogens definitely cannot be methylated, but one can, as we will see in methotrexate with it increasing activity, but one of them can be free, because we did mention you do require that this compound exhibits some form of acidity, and therefore you do require one of the hydrogens, because the barbiturates require to be acidic for them to have activity. And we have discussed all this, so we don't need to go back there. So the end, if you look at methotrexate, which we have here, so you can see methotrexate is an example. It is definitely has one of its nitrogens methylated, but you can see the other one is free. So one of the nitrogen is methylated, but the other one is free, and that is necessary for activity. The N-methylated barbiturate, that is more basic than the non-methylated barbiturate, and of course it will be more basic because the methyl group is an electron donor, and if the methyl group is an electron donor, it will donate electrons to the nitrogen. Remember, basicity is the ability of any group to accept protons, and therefore once the methyl group donates electrons to the nitrogen, then the nitrogen will be more basic. It will have a higher tendency to attract protons, and therefore more basic nature. The higher pKa, of course, remember, the higher the pKa, the lower the Ka, and the Ka is the dissociation constant, and the dissociation constant, if it's a dissociation constant of the acid, and therefore if the dissociation constant of the acid is low, it means it is a weak acid. So the higher the pKa, or weaker the acidity, or weaker acidity, increases the concentration of the lipid soluble free acid form at physiological pH. Because once it's a weaker acid, remember, once you donate, you push in electrons. Remember, the barbiturates are weak acids. by nature because of that hydrogen and because of the carbonyl groups they have. The carbonyl groups are electron withdrawers, so the hydrogen on the nitrogen is highly susceptible to be lost. And therefore, once you have a weak acid, and then you push electrons into that weak acid, you make it a more weak acid. Once you make it a more weak acid, its tendency to ionize as an acid is reduced. And once its tendency to ionize is reduced, it becomes better. It is less ionized, better independent. The lesser ionized, the better the penetration of the lipid membranes, including the lipid membranes, especially the BBB, the higher concentration you will have in the brain and the higher its activity. So that's what we are saying, that because of the fact that you put the methyl group, this methohexyl is a weaker acid, less ionized at physiological pH, at the less ionized it is, the non-ionized moiety will have been higher concentrations, better penetration of the BBB, gives us a high concentration in the brain, and you give the person a knockout. And that is an advantage of that methyl group. And therefore, the methylated methohexyl will have much higher activity than the non-methylated barbiturate of having the same other substituents, even at position number 5. And methylation decreases the duration of action due to the high rate of deputization. Again, the methyl group increases lipid solubility. So the methyl group has two things. It increases lipid solubility, it decreases ionization, and of course, in increasing lipid solubility, there will be more deputization or more redistribution, and therefore shorter the duration of activity. The shorter the duration of activity, the more rapid the recovery, and therefore the better the drug becomes as a general anesthetic. It has, of course, extensive hydrophobic character because of the long unsaturated side chains. If you, of course, look at this drug, just like thiopental sodium, you can't see it as these long groups, these big hydrocarbon groups. Of course, it has one disadvantage because of the the unsaturation, and unsaturation within the alkyl chain promotes, of course, metabolism. But nevertheless, if you look at that, that's 1, 2, 3, 4, 5, 6, very similar to the thiopental 6, 7, 8, 9. So it has a large number of carbon atoms within its hydrocarbon groups. And of course, as I have said, the only small drawback is the fact that, of course, there is unsaturation, and unsaturation will promote metabolism. But once it promotes metabolism, that means the drug will not again linger in the body for too long, and therefore it will give us good recovery, but of course short duration of action. So it has extensive hydrophobic character because of the long unsaturated side chain, which has 9 carbons. It can rapidly penetrate the CNS after IV injection and then redistribute, as we have said, rapidly to other body sites and undergoes rapid metabolic inactivation. So those are some of the characteristics, and these are, we can be able to get them from the structure. 1, high lipid solubility, because 1 of the methyl group adding lipid solubility. 2, also because of the methyl group pushing electrons, making it a weaker acid, and therefore we have the more lipid soluble non-ionized moiety, and therefore, and of course also the final one, the fact that it has very large hydrocarbon groups at position 5 of this compound, and therefore rapid penetration of the BBB, but of course high redistribution, and of course also high metabolism, as I have said, because of the unsaturation. It has accessible sites of metabolic inactivation, the methylene alpha to the triple bond. So methylene alpha to the triple bond. So we are only saying because you have this group here you can see this is a triple bond here. You have this methylene alpha to the triple bond. That group can undergo rapid oxidative hydroxylation because of the unsaturation, can undergo rapid oxidative hydroxylation, and that again further reduces the duration of action, and therefore helps us in what we call the recovery, because we say they should also have give us rapid recovery. So when we look at these drugs, we see why we use them and we will not go for the others we had planned before. We go for these ones because their structure allows them to give us the characteristic. They have the structural features that are needed for us to have the best characteristics for general anesthesia. But as we say, because of their short duration of activity, they will be given together with other anesthetics, so that they'll be given with other drugs or other anesthetics for us to be able to maintain the anesthesia for as long as the operation occurs. But immediately you finish off with the operation, then in case there is any of them left in the body, they will either be metabolized or they will undergo depotization or redistribution, and therefore the patient will recover slowly. Of course, they will, even with the redistribution, they will still have some of the effects of these drugs. But of course, when you get redistribution and they are being metabolized, the concentrations now go down, and they will not be enough to trigger or to bring about the anesthetic activity. So you can check up the metabolism, as I have said. I think we had discussed it earlier. I don't know whether there is anything else. I think that finishes the general anesthetics. So please check up anything we did about the barbiturates, which I might not have mentioned because we had discussed them. We had discussed how they undergo ionization. Those are things that we had discussed, so you can refer and understand. Do you have any question? As I say, these are shorter groups, simpler, also shorter groups, and therefore much easier. That's why I usually start with the narcotic analgesics. They have slightly more complex structures. It's a much lengthier topic, so that when as we finish with this one, it will just be almost a walk in the park. Not much, not complicated, with what we have learned along the way. Also, with the kind of farm game we have done, I don't think it's in the cause of alarm. So we are done, thank God. And we are done with the general anesthetics. At least we are done with the whole of that subtopic. So when we meet next, we will now be looking at the muscle relaxant. The muscle relaxant is relaxants, centrally acting muscle relaxants only. Try to classify them. There are very few. Then try to classify them into the different classes according to their structure. Very few. I think we'll be able to finish that class. I mean that unit, that topic. One lesson I think will be enough. And then now we'll be left with the hallucinogens and the CNS stimulants. Again, not very complicated. So are there any questions? Are we okay? Tuko salama, tuko sawa? Swali. Yes, to the high molecular weight into carbon chain enhances air and liquid water partition, because therefore this increases the enhances entry into the brain through. Yeah, that's correct. Tuko salama. Any question? Today I had 27. Where are the other students? What is mko na makat? Wanasomea kat or nini? Or they didn't want to come for the class? Anyway, you are adults. So I told told Frida, before we go for the elections, we will do the next cut for the anti-cancer drugs. Again, only the anti-cancer drugs. So that when you come back, we have another 2 cuts and we are done. So keep reading. Keep reading. I hope you did the cut well today. I will start marking tomorrow. So I want to finish as quickly as possible. Any questions? I hope are you doing any practicals? You answer me through the public chat. Have you done any practicals? Not yet. None at all, the whole semester, for the 2 units. Oh, okay, sawa. Let me talk to Nani tomorrow. Itwaje.